I'm Robert Schertzer, Clinical Associate Professor, University of British Columbia, Department of Ophthalmology and Visual Sciences, and Director of the West Coast Glaucoma Center in Vancouver, British Columbia, and we're talking about glaucoma with episode number 11 for mid-March 2010 with my guests Joel Schuman and Claude Burgoyne. Today's topic, nerve fiber layer and optic nerve head imaging. Please check the show notes of this podcast for definitions and references related to HRT, GDX, and OCT imaging devices. You will also find links to follow me on Twitter, where I am Rob Schertzer, my glaucoma, EMR, and tech blog, wholelotofrob.com, and my website, westcoastglaucoma.com. Welcome everyone to this week's episode of Talking About Glaucoma, and today we're going to focus on imaging. Oh, I didn't mean to put that pun in there. But we have with us today Joel Schuman from University of Pittsburgh Medical Center. Hi, Joel.
Hi.
And Claude Burgoyne is with us from Drs Eye Institute in Portland.
Hi, Robin. Hi, Joel.
Hi. I guess we could start by each of you just introducing yourselves just briefly and what you've been doing in recent years in terms of imaging. I'll start, though, by saying that Joel, as many of our listeners probably know, was one of the inventors of the Optical Coherence Tomography and continues to make new advances in this technology. And Claude has made some amazing contributions in recent years with research in Spectral Domain OCT. In fact, one presentation at a meeting, I forget what year that was, it was so overwhelming to everyone that it even blew up your computer.
Yeah, I would say that's more of a reflection on the operator than the presentation. That's hot stuff, huh?
Yeah, totally. Yeah, so Joel, mind you give us a little blurb about yourself, and then Claude.
Okay, Joel Schuman. I'm at University of Pittsburgh. I've been in Pittsburgh for about 7 years now. Before that, I was in Boston, and while I was in Boston as a fellow, became involved in research in laser tissue interactions, and was working in Carmen Puliafito's laser laboratory, and then became aware of a project that was going on with optical coherence domain ranging. This was looking at the distance between surfaces, so that was looking at the distance between the front and the back of the cornea, and it was a project that wasn't really going anywhere for a number of reasons. And that project, though, was using this OCDR that had a near-infrared wavelength. And it occurred to me, despite my lowly fellow status, that this was a wavelength that could get to the retina. And I went in to talk to Carmen Puliafito, who was the head of the laser laboratory, and told him my idea, and he said that it would be okay for me to go over to MIT and work with his collaborator, Jim Fujimoto. And at that time, David Huang was an MD PhD student. David is now at USC, as is Carmen Puliafito. David's a professor with a subspecialty in cornea, and Carmen is the dean of the School of Medicine at USC. So Jim Fujimoto, who is still at MIT and still a collaborator, had created a laboratory where OCT eventually was born. And on that day that I went over to do some experiments with David Huang, I brought over some calf eyes, and we hemi-sected them so that we could put the retina, essentially the half of the eye with the retina, under the OCDR beam. And we set it up and went out to get some Diet Cokes because it took about 20 minutes to do a single scan. And it turned out that, indeed, we were able to get signal. And we saw the spikes from the retina, and that was the very first OCT or OCDR of the retina. OCT actually didn't come into being until David had the insight that you could scan transversely, which seems obvious now because you do with the ultrasound B scan. But at the time, nobody had done it, and the best ideas seem obvious in retrospect. And that was a major contribution from one of his many from David. And so that scanning allowed you to take a series of A scans, put them together to create an image, and that is what we now call OCT, or Optical Coherence Tomography.
And we no longer need to dissect the retina out of the patient's eye and leave them for 20 minutes before coming back.
Yeah, not anymore. It would have been tough to get through the cloudy lens in those calf eyes, though.
Yeah. Well, thanks. That was some history there I wasn't aware of. And Claude, why don't you fill us in briefly on what you've been up to?
Surely.
Your background.
I've really dedicated my research career so far towards understanding the engineering of the optic nerve head, working with biomechanical engineers to do that. And the approach that we have taken is to work in the monkey model of experimental glaucoma, where we have the ability to sacrifice the animals at the end of our studies, and then have obtained the capabilities of building very high-resolution reconstructions of the optic nerve head tissues. And all of the capabilities that we built in that regard, so as to be able to make very accurate measurements of how the tissues change as the monkey eye makes the transition from ocular hypertension to early glaucomatous damage, are then used by the engineers to build progressively more sophisticated finite element models to try to understand how those changes occur. Well, from our standpoint, we have been looking for how to translate this post-mortem histomorphometric knowledge into clinical, into the clinical realm. And we needed to do that in order to make progressively more sophisticated models of the eye, with the ultimate goal being to acquire the ability to capture the kind of anatomy clinically that we now possess in a post-mortem sense. With the emergence of OCT imaging out of all of the people that Joel mentioned, and by the way, I hadn't heard that story either, so that was a pleasure to hear. We certainly saw the potential for trying to do that, and so I think what we have been doing over the last several years is trying to use the state-of-the-art techniques that we are able to get through collaboration to convince the rest of the world that we can actually apply these imaging techniques to the deep tissues of the optic nerve head. And I think Joel will tell you in a little while all of the very important work that's been done on imaging, using these techniques to image nerve fiber layer for all the right reasons. But the nerve head itself has been very difficult because of the blood vessels and many other reasons as well. But I think with the current advances, particularly in spectral domain imaging, which has increased the speed to such a degree that you can get enough A scans in a clinical imaging session to begin to build accurate reconstructions, that we're on the verge of being able to obtain the kind of optic nerve head anatomy to see changes that I think will be very early in the neuropathy and lead us to a lot of new insights, which not only will have very important research implications, but will also, I think, potentially have clinical implications. So
right, and
kind of the context for what we've been doing in these regards.
That's incredible work, and that's really getting down right to the cellular level in these images, in the living human. I guess it's the ultimate goal.
Well, I think Joel probably will address this because I know you want to bring a bit of the conversation to metabolic or cellular activity.
Right,
and,
exactly.
That certainly is on the very cutting edge of this technology. But everybody, if we get into a discussion of structure versus function, I think the intersection of this ongoing debate in glaucoma is going to get down to the structural detection of cellular function. And we will get rid of the confusion over structural versus functional timing of progression in the neuropathy when we get to the ability of structurally detecting that cells are not any longer happy in their environment. And maybe we'll get to that in a little bit.
Right.
So it's interesting because we can really, with Claude's introduction, we can start in the future, and then we can work our way back to the past and the present. But in terms of, Claude, in terms of what you mentioned with optic nerve head imaging and looking at the deeper tissues, I wonder if you think that it would be possible to identify parameters within, let's say, the lamina curvosa that will give us those earliest cues about the potential for damage, the degree of damage and the potential for damage in a given person's optic nerve.
That's a great point, and of course, Joel's being gracious. He knows that we're both very interested in this subject from our previous conversation, so he's kind of pitching me a soft and easy pitch to this. I think that, there's two themes that I would develop in this conversation, and one is the clinical detection of change, which will aid us in knowing that a particular patient is not enduring their current level of risk factors, one of them being intraocular pressure. And then there is the ability to predict susceptibility. And certainly the science that myself and my group of collaborators have dedicated ourselves to is to try to really go after the building of a science that happens to be based in engineering on predicting susceptibility. In other words, finally providing a science for setting target pressures and perhaps for other risk factors that contribute as well. And in order to do that, what Joel has alluded to is we have to have anatomy. And so we have to be able to capture ultimately, in order to do this, from what we understand so far, you're going to have to be able to describe what the engineers refer to as geometry, which I refer to as architecture. In other words, the three-dimensional anatomy of the connective tissues and then ultimately the neural tissues in the cells and the blood vessels that all combined make up this tissue environment that we call the optic nerve head. You need the anatomy, and then you need to be able to evaluate it dynamically in an individual eye, in an individual patient. And that's what we're hoping this technology is on the verge of giving us. And, I think probably at some point we'll start talking about differences in wavelengths and differences in bandwidth of the devices that are currently under development. And one of the things that Joel and Jim Fujimoto have pushed, along with Wolfgang Drexler, are the exploration of the next generation of wavelengths that are giving us deeper penetration into the tissues for just the reasons that both Joel and I have just alluded to. Ultimately, we're going to need to really capture the full anatomy, the full thickness of the sclera, the full thickness of the lamina, and then be able to watch how that moves over the course of prescribed fluctuations in intraocular pressure in order to understand how stiff or how compliant those tissues are, and then ultimately, see at what level of intraocular pressure, for example, capillary flow within the laminar capillaries or within the posterior ciliary arteries as they pass through the peripapillary sclera to achieve the choroid or the prelaminar nerve. At what level of intraocular pressure in a given eye does that blood flow stop or is diminished? And we're not there yet, but I think that we're on the verge of beginning to achieve some of those goals for clinical imaging, and that would open up a whole new era of predicting susceptibility. which I think we are separate from the issue of detecting change in clinical patients, which we are already in the era. I think this next generation of prediction would have to do with what's a safe level of intraocular pressure, what's a safe level of blood pressure or perfusion pressure for a particular eye.
Right, and it sounds like we'll also be fusing together vascular and mechanical as just one unified theory of damage.
Yeah, I think that looking at the optic nerve in the way that Claude's described is fascinating, and it is really a novel target for the detection of glaucoma and the susceptibility to damage and in the future, as well as evaluating progression. And there are a number of questions, I think, that need to be answered in looking at the tissue. And one is, what about the architecture or the geometry is important? What's relevant? Is there relevance to the structure of the laminar curvosa, the shape of the beams, the thickness, how they change, how the spaces change when you perturb the system by modulating the intraocular pressure? I think all of those things will be important in assessing an individual's susceptibility, and that's, we used to say that the Holy Grail was the detection of the disease, and then it was the detection of progression, and now it's predicting the future. And knowing whether or not somebody's likely to be a fast progressor or has, aggressive disease, I think will change the way that we manage our glaucoma patients in a very realistic way.
Well, maybe we could go backwards in time to the present and then try to figure out the steps that are needed to get us to that future we were just talking about. I guess, at least for me, the present standard is with the HRT, Scanning Laser Ophthalmoscope, and in this case it's confocal slices of the optic nerve that are reconstructed into a 3D image. And then at least one of the analyses that's performed is comparing that to a mathematical model of a 3D reconstructed nerve that has glaucoma to help predict how likely this particular optic nerve is to get glaucoma. And then it's also very sensitive in looking at changes in these scans over time with the topographic change analysis. But compared to what we've been talking about in this conversation, that seems really crude in comparison to where we hope to get in the future. So what is it going to take to get us from where we are now to those next steps, to applying these things in living humans?
Actually, before we go to how we get from where we are now to where we talked about, can we talk about where we are now for a second?
Oh, sure. Yeah, keep on that.
Because with the confocal scanning laser ophthalmoscope, as with scanning laser polarimetry or OCT, we're now able to detect the presence of disease or the absence with a fairly high degree of sensitivity and specificity. So our ability is so much better now just using an instrument to, in a standardized way, assess the patient to determine whether or not disease is present than we were 10 or 15 years ago.
Mm-hmm.
And so I think that what these devices do at a minimum is to bring all people using the device essentially up to the level of an expert examiner, and it does a standardized evaluation. That's not to say that you don't need to interpret the image, because you do. And you can have a poor quality image or a bad quality analysis, and it's the garbage in, garbage out problem that you need to deal with. So you still have to analyze the data that you get from the machine But it's much simpler to analyze those data than to look at a disc and say, yeah, this disc is damaged, and it's damaged in this area in this particular way, because you have the ability to do this standardized optical analysis of the tissue.
Good.
So, if I would add something to what Joel said, I would just say that the topographic assessment that you've alluded to and explained, Rob, I think has been a very powerful advance for all the reasons Joel said, and for which has to do with deciding at the time of a single visit or cross-sectionally how likely somebody has damage.
Right.
And then separate from that, I think the development of the change progression analysis has been a very powerful advance. And we can get into an argument or a discussion about what is clinically important surface change, because that's what that device detects, separate from what is statistically significant surface change. In other words, how much detectable change that exceeds variability represents a clinically important amount of change, and we're sort of, I think that we are in the phase of having discussions about that, but that's an achievement in the sense that we now can detect change relative to variability.
When you're saying clinical change, you mean, I guess to clarify that would be something that would prompt us to decide whether we need to change current treatment or initiate treatment, right?
So, how much change on a TCA map that meets the statistical criteria for red and green dots,
right.
At what point do you intervene based on what you're seeing? Do you believe it enough to make the decision to alter the patient's current, in this case, level of intraocular pressure? That subject is still certainly not known. But the point is, surface, I think that's an accomplishment. And then we need to talk about the measurements of nerve fiber layer thickness and retardance that have occurred in parallel to that, which I think Joel might be better suited to discuss where we're at in that regard.
In terms of nerve fiber layer thickness, I think the same can be said as what you've described about looking at the presence or absence of disease, so disease detection, and also progression detection, as with the CSLO, with the Confocal Scanning Laser Ophthalmoscope. So scanning laser polarimetry uses polarized light that is shown into a patient's eye. It's reflected back to a detector, and then you mentioned Claude retardance. The change in phase is measured, and that corresponds to the amount of birefringent tissue that the light has passed through. And the retinal nerve fiber layer is birefringent. You have some other birefringent tissues in the eye, the cornea, and the lens, the retinal pigment epithelium, the choroid is probably birefringent, the sclera is birefringent. So you have a lot of other birefringent tissues, and we only want the information about the nerve fiber layer in this case. And so there have been several iterations of scanning laser polarimetry that have come to market over the past 20 years. And what we have now is a device that most of the time can give an accurate assessment of the nerve fiber layer. Some of the time will give what's called an atypical scan. In other words, a scan is confounded by other birefringent tissues so that it's not giving an accurate assessment. And you can tell the difference clinically, roughly, by the pattern of birefringence. In other words, if you have the expected bow tie pattern with a lot of birefringence superiorly and inferiorly that go out in an arcuate pattern, that's probably true nerve fiber layer as opposed to patchy birefringence that appears in random places in the image, which is usually noise. It's this atypical image. But so scanning laser polarimetry has come a long way, and we're now at a point where it does very well for disease detection. And there are articles that are starting to come out now with regard to measuring progression with this device, and there's software that's available now for progression detection using scanning laser polarimetry. So again, same story as what I said before, where you have a standardized way of assessing the parameter, in this case progression, and it brings the examiner up to an expert level. For optical coherence tomography, you're using near-infrared light and looking at the reflection back, again, from the retina. You don't have the problems of birefringence. You're just measuring the back reflection of that light, and in that back reflection you have varying intensities. Those intensities correspond to structures. The nerve fiber layer is very highly reflective, and it turns out that you can use algorithms to segment those different layers within the retina, and in particular the nerve fiber layer. And so we can measure nerve fiber layer thickness relatively directly from the OCT image. And initially we were doing that as a circle around the optic nerve head, centered on the optic nerve, 3.4 millimeters in diameter. And then and the purpose of that was to capture all 360 degrees of the nerve fiber layer. And now we're able to do that in 3 dimensions, as Claude alluded to before when he was talking about the optic nerve. So we can get a 3-dimensional volume of the retina centered wherever we like, but right now we're centering on the optic nerve or centering on the macula, and then we're able to segment out the tissue layers, in particular here the nerve fiber layer, and the nerve fiber layer that can then be assessed in that entire volume of tissue as opposed to just in a circle around the optic nerve. Also, a circle can be created around the optic nerve, and it can be done post hoc, so that you improve the reproducibility of measures because you're always putting the circle in the same place, as opposed to with the older iteration, the time domain OCT, the technician had to place the circle, and you were never quite sure exactly where the scan was taken from. It was taken from around the same area from time to time, and the reproducibility is good, but it's not as good as if you're placing the circle on a OCT volume where you know that that circle is centered in the same place over the optic nerve every time.
Now, is this only with the spectral domain OCT?
Right, and so like Claude said, the spectral domain OCT is much, much faster than time domain OCT. So Stratus is time domain OCT, and all of these others are spectral domain OCT. And with the spectral domain OCT, you're acquiring scans on commercial devices from between 27,000 and 55,000 A scans per second. So there's no more going out and getting a Diet Coke while the A scan is happening. They're happening very, very fast. And that's what allows us to get the 3-dimensional data sets that we can then analyze post hoc.
Right, because with the slow scan of the time domain, you would actually also have eye movement issues to keep you from actually measuring the exact same spot between scans. Isn't that correct?
That's exactly right. It's, in fact, maybe even a little bit surprising that the measure is robust enough so that the reproducibility is fairly good if you're looking at the mean nerve fiber layer thickness. So the standard deviation of measures is about 2.5 microns when you're looking at the mean nerve fiber layer thickness in that scan circle. With spectral domain OCT, we're down to about a 1 micron standard deviation of measures. So just by taking this circle post hoc, we're improving the reproducibility of measures. And we'll talk in a couple of minutes, I guess, about going beyond the circle and using all of the other information that's in the scan as well.
Right. So we're now able then to do a post hoc circle that's a certain distance from the rim of the optic nerve as opposed to this 3.4 millimeter cookie cutter?
So actually, that's an interesting question. I'd be interested in Claude's take on this too. So being the person who came up with the idea of doing a standardized circle, the 3.4 millimeter circle centered on the optic nerve, the reason that I thought that this was a good idea was because it didn't depend on the size of the scleral canal or Brooks membrane opening, and it would allow us to sample the retinal nerve fiber layer in roughly the same place in all eyes within a given range of axial length. And so that standardization was the reason that I wanted to have a 3.4 millimeter circle, the same size in everybody, as opposed to a variable distance from the edge of the optic nerve. And I think that it does give a measure that's more comparable between people than if you were varying the circle size. But I'd like to hear what Claude's opinion is. Maybe it's different. Maybe I'm off.
Actually, I have a couple of thoughts about it. I think the first point to make is that volumetric reconstruction of the nerve fiber layer that Joel is alluding to, that we will end up having a better assessment of nerve fiber layer, total nerve fiber layer volume, or some portion of the total nerve fiber layer volume, so that we can better compare between eyes, and it may be better than the logic that Joel's employed for the circle scan. There's certainly, the first thing to be said is there's no obvious way to do this best at the current time, but I think that the volumetric reconstructions will allow us to get a better assessment. Ultimately, what we are after, I think everybody recognizes that what you're after is a quantitative assessment of the total number of axons in the eye,
right.
Which can be estimated from a volumetric assessment of the total nerve fiber layer when you begin to make assumptions about the average density of axons, which those assumptions have lots of problems associated with them. But what I would say specifically to Joel's question is whether I think that's a good idea or not. Is I think the jury's out until we have the kind of volumetric reconstructions in enough eyes, and then begin to play around with the best way to look at those. That gives you the best ability to compare differences between different eyes. Ultimately, I think that they're going to need to be linked to, or they're going to need to be compared to actual axon counts. That's something that we're ultimately interested in doing in the monkeys that we're studying, and because we happen, between my collaborators and myself, we happen to have quite a large number of animals that we will end up with well over 100 normal monkey eyes in which we will have very good OCT imaging, and we'll have the benefit of orbital optic nerve axon counts. And we hope to begin to lay some foundations for how to best look at that volumetric data to predict total axon numbers. That's further down the road. So I think the volumetric scans that Joel is alluding to is going to give us a better sense of where actually to make that measurement in most eyes in order to have fair comparisons. I guess that's where I would leave it. Our own approach, we're just in the process of generating large numbers of volumetric reconstructions. And so our intention is to look at this in a systematic way. Our intuition is some distance away from the edge of the disc margin, but I don't have a lot more specific to add.
I'll be really interested in those studies. I don't know which is best either, and so having the data is always a better way of making a decision.
Well, I think the point is that, Joel, that the important step is the volumetric reconstruction. I think that's going to end up providing us with another sort of a next generation logic for where to make the measurement, and so that's the most important thing for everybody here. Two things that I think will be themes that we'll come back to, but I want to make one point now, and that is the segmentation that Joel mentioned and has been very much a part of the development of the automated segmentation of these measurements is a second aspect of the work that has allowed many of the advances that are occurring. And so, for example, for all of our own work, particularly in the nerve head, everything has to be what we call hand delineated, and it's a technique that has come directly from all of our work in histomorphometry. The automated segmentation of the nerve fiber layer itself is now pretty well established for most all of the instruments, and that's been a fairly approachable target. I won't say easy target because I know a huge amount of work that's gone into it. And, progressively we're working towards some of the other basic structures that ultimately will be necessary to make good measurements. Bruch's membrane, the determination of Bruch's membrane opening, all of these things will really advance our abilities to quantify these images. So a lot of the advances that we're looking at are going to be dependent upon those kinds of software issues, and so you need to follow the development of those as they occur. The second point I want to make is about that Rob and Joel both alluded to was Joel's point about the importance of achieving three-dimensional reconstruction was one of the huge advances that comes from that is exactly what he alluded to, and that is a much more accurate retrospective assignment of measurements within volumes of the same eye acquired over time. And in parallel to that development is occurring progressively within the commercial instruments eye tracking that allows, at the time of acquisition, for A-scan patterns to be acquired in precisely the same location that they were on previous occasions. So this is a bit of a subtle point to make, but by acquiring volumetric data, you can retrospectively go back and look at the same location over time. It's an even further advance to be able to acquire data sets at the same location every time they're acquired. And I think progressively now, most of the commercial instruments are employing that technology, and that's a huge advance, which is separate from the technical advance of spectral domain imaging, that has made everything faster. There are two separate issues that have occurred in parallel that have really advanced our ability to create accurate volumetric reconstructions that can be compared over time.
I think there are a couple of ways of achieving that goal, and the goal being registration of images, essentially, right?
Yeah.
And you can do that through tracking, or you can do it through post-hoc software modification of the image so that you align and register. There's work that's being done in a number of places, including Hiroshi Ishikawa's work here, and in collaboration with Intel Corporation and with Georgia Tech. And the ability to register images, as Claude was saying, I think will be very powerful and enabling much higher still reproducibility of measures, and that should enhance our sensitivity and specificity for being able to detect disease and progression, as well as the work that we started out talking about, which is the future work in looking at compliance or prediction of the likelihood of progression of the disease.
Yeah, and two additional points about that, and I think I've forgotten the first one already. I know. And maybe I'm a bit peculiar about this, but the kind of registration that Joel is alluding to is a little bit different than the point I'm going to make, but it does allow the co-localization or registration of the OCT volume to clinical photographs. And while this is not necessary, absolutely necessary for the data to be very useful, I personally really emphasize to everybody that I interact with about this, the importance of always having a clinical photograph that's co-localized to the OCT volume that you're looking at, because it really greatly enhances your understanding of the OCT visualized anatomy. And frankly, all of us are struggling, and we will continue to struggle with understanding what we are seeing in the OCT images, because I believe that none of us really actually understand the anatomy well enough three-dimensionally to make sense of the OCT images. For the most part, so far, the OCT seems to be getting the anatomy, and we need to readjust our understanding of it in order to appreciate that it is. Now, there's lots of caveats to that, but
well, the reflections are different, right? The reflections from the OCT are going to be different than what we see on histology, where light is passing through the tissue.
Yeah.
And it's also in vivo instead of processed tissue.
Yes.
And so there are enough differences where I think that we're, just like you said, we're seeing new things. They're probably real, but we also don't really know exactly what they mean. On the other hand, we have to be careful not to overread the OCT, because there can be artifacts and errors in there too.
Yes. And the other thing that's I want to mention is, this is out of Joel's group, it's Hiroshi's work on creating new planes in which to visualize OCT data. It's funny because I've always, as we looked through our histomorphometric reconstructions, there were a couple of things that all became very apparent to us. The tissues had never been able to be looked at this way before. And number one was that motion itself was very important in depicting or realizing and recognizing surfaces. Moving through something allows your brain to process, and you can see surfaces that you can't see within individual images. And that was one thing that was important. The second was that visualization really is a hypothesis-forming step in the process. It's just really important to build the ability to visualize these data sets well, because you learn so much from that process. So visualization by itself is important. And the third was that, when you look at histologic sections, you never are in the actual plane of the anatomy. So, for example, you'd like to be able to look at the plane of the sclera, which is, of course, a sphere. And you need to then cut the volume in a spherical shape in order to follow the plane of the sclera as you're looking at it, or the plane of the lamina. And Hiroshi, if I remember correctly, has really implemented that kind of viewing capabilities within OCT volumes. And I'll switch over to Joel at this point.
Yeah, it's a malleable C-mode plane. So saying that in plain language, puns not intended, but what you're able to do is to adjust your view to a given tissue layer. And you can look specifically at that tissue layer, and you can move through it. So if that tissue layer is the sclera, you can adjust the plane to the sclera, and you can look through that. The tissue plane is the internal limiting membrane. You can, again, adjust that plane, etc. So bringing out things like pigment epithelial detachments, or epiretinal membranes, or central serous chorioretinopathy. There is so many different things that you can see when you've adjusted the plane properly, so that just like when you're doing surgery and you're dissecting, you want to be in the right plane. And when you are in the right plane, things look a certain way, as opposed to when you're cutting through a variety of planes. This allows you to surgically dissect the correct plane, but that surgery is being done optically. So it's a true optical biopsy. One of the really interesting things is the vasculature of the macula, and you can see the different types of vasculature within the different layers of the macula. It's different in the ganglion cell layer or in the interplexus, in the internuclear layer or the outer nuclear layer. If you look at the vasculature in those layers, they have different types of vessels, and those vessels have different patterns.
And my prediction is that, and we don't yet have this facility to look at data in this way, either within our histomorphometric volumes or our OCT volumes. And it's been something that I've wanted to move up on our priority list for software development. We just haven't gotten there. But the comment by Joel about the macular vascular pattern is an interesting one, and not surprised to hear that. And I think the same thing will be true as we look at the circle of Zinhaller vasculature and the laminar capillary takeoff from the circle of Zinhaller. I think that the complexity of this is very, very, very difficult to appreciate from standard histologic sectioning, and it really will require that kind of visualization plane to better appreciate this complexity, and particularly if in terms of trying to understand how it changes with age and with disease.
So it's all incredible stuff in our future, but maybe we could try to reel this back to today and what we should be doing now with our patients. But we don't, a lot of people don't have all of these instruments. Some of us have one of them. And any recommendations for what people should be doing now?
I think that all of the instruments have shown themselves to be pretty good at disease detection, and we're starting to see data come out now on progression detection for all of the instruments. HRT, there's been progression detection validation for some time now, but as Claude mentioned, the statistically significant and the clinically relevant may not be exactly the same, and so we still require interpretation, as I mentioned, of the images for the detection of disease, but also for detection of progression. Is this really a relevant change that we're seeing, or is it just a statistical anomaly? And so I think that we have technology that's clinically useful, that's available for the clinician now, whether it's confocal scanning laser ophthalmoscopy, scanning laser polarimetry, or OCT. OCT is probably the technology that's changing the most rapidly, and that's being driven by the fact that you have multiple different companies that are now making the OCT device and the Spectral Domain OCT device, and that's driving innovation, and I believe it will also drive the price down.
Oh, that's good, because it is expensive. It's also, even though it's driving innovation, which is fantastic, but it also has excluded the old data with each new generation, which has been a little bit challenging if you're trying to follow your patients over time, and you can't use that old data to see if they've progressed.
Yeah, there's a paper that we just published. It's actually possible to use the Stratus data, the old time domain data, with the Spectral Domain machines, using specialized software that was created again by Hiroshi together with Jang-Shik Kim, the first author on that paper, and it allows that sort of backward compatibility of the technology. Unfortunately, it hasn't been implemented by any of the companies, and so if anybody's out there listening from any of the companies, give us a call at University of Pittsburgh.
That would be great. Any other clinical correlates from Claude?
Yeah, I would just add to Joel's comments. I would say two points maybe. On a very practical level, for somebody who is not going to be able to afford all of these technologies, I think that choosing to stay with surface topography or nerve fiber layer thickness, whether it's by the current generation of OCT images or not. If you have to do that, I would recommend staying with one and continuing going forward. That's a hard decision. But one thing that's going to come out of OCT imaging is surface topography. It's just a matter of time. In other words, the data to create surface maps based on volumetric OCT imaging is there. The ILM is beautifully imaged. And from my own bias, the fact that you will capture enough information about the neural canal opening, which is some relationship to Bruch's membrane opening, and use that as a reference plane. I do believe that reference plane is going to be a better long-term reference plane, or some variant of it. It may be that the actual reference plane ends up some distance away along Bruch's membrane. But the fact of the matter is that one of the benefits of volumetric reconstruction, I believe, is going to be a much more stable reference plane. Not that it will not itself change through the neuropathy, but it will change a lot less than the surface of the internal limiting membrane, which is what's currently used now for surface topography. So, the equivalent of TCA change is eventually going to emerge from volumetric OCT imaging. And so I think that concept will be eventually a part of OCT imaging. And there will be, I think, better reference planes for all of our measurements. Once we work towards development of those, I think the data is going to be there in volumetric reconstructions. So, and the final point is just there's a huge, Joel alluded to it earlier, but there's a huge developing push towards the characterization rate of change rather than event-based, using event-based criteria for change detection. And the importance of that is that the goal of that will be to identify the people who are either progressing most rapidly over the course of the initial period of time you're watching them, or they're at risk for progressing rapidly. And then the importance of that is that we will then presumably focus our efforts on following those patients more closely and treating them more aggressively. So all of these technologies are set up for characterization of change in terms of rate of change over time, and people should bear that in mind as they go forward.
And you're talking about one day having something equivalent to the glaucoma progression analysis on the Humphrey for this sort of data, giving a predictor of
the glaucoma progression analysis is an event-based characterization of change. I think that the more apt analogy would be to something like progressor software, in which you do linear regressions of every individual point and or the pooled parameters like PSDI, and there's a recent paper, a series of papers from Anders Heil and Dale Shahan, Ted Garway-Heath about rate progression using visual field data. I think all of this is going to come into structural imaging as well within the next 5 years, and people are going to progressively need to be aware of the fact that they're going to be looking at linear regression change in addition to event-based criteria like, okay, this person's now out of their range of variability. We need to confirm that one or two more times, an event-based approach.
Great. So all glaucoma specialists can be replaced by machines, and we'll all be able to retire.
No, their job's not going to happen. Not going to happen. We still need to be docs. We still need to analyze anything that comes out of these machines.
That's right. I mean,
and the clinical correlation also is critical with any of these data.
Yeah, absolutely. They're all just things that we correlate with the clinical picture and bring the patient in and the decision-making to figure out what we're going to do about it. Well, thank you both, Joel and Claude. We certainly covered a lot of territory in our more than 10 minutes of discussion on imaging. I guess we could just call this a wrap then.
Well, that was great. Okay? Thank you so much. It was a pleasure.
Yeah, thank you.
Yeah, thank you very much.
Okay.
Pleasure too. Nice talking with Joel and Rob.
Good.
Take care.
Bye-bye.
Bye.
Bye-bye.
That's our show for today. Be sure to subscribe via iTunes or RSS feed so you won't miss an episode, or follow me on Twitter to learn more about upcoming episodes and other news about glaucoma, electronic medical records, and technology. I produce Talking About Glaucoma approximately once each month, or as time permits, in AAC format that includes chapter markers and show notes, and mp3 format that does not. Once again, on Twitter, I am Rob Schertzer. My blog is wholelottarob.com, and my website, westcoastglaucoma.com. Look for me everywhere. Please help detect and treat glaucoma by keeping yourself informed.